Welcome to the Board of Health meeting of November 4th, 2024. Please note this meeting is being recorded and will be available shortly hereafter for scheduled and on-demand viewing on any smartphone or tablet. If anyone else is recording this meeting, please notify us. Pursuant to Governor Healy's March 29th, 2023 signing of the Act of 2023 extending certain COVID-19 measures adopted during the state emergency, suspending certain measures of the open meeting law until March 31st, 2025, this meeting of the Chatham Board of Health is being conducted in person and via remote participation. Every effort will be made to ensure that the public can adequately access the proceedings as provided for in the order. A reminder that persons who would like to listen to this meeting will, while in progress, may do so by calling 1-508-945-4410, and the conference ID number is 953-277-16#, or you may join the meeting online via Microsoft Teams through the link in the posted agenda. While this is a live broadcast and simulcast on Chatham TV, Channel 8 and 1072, despite our best efforts, we may not be able to provide real-time access. We will post a record of this meeting on the town's website as soon as possible. And now I'll turn the meeting over to our chairman, Dr. Noble Hanson.
Thank you. It shall be the policy of this board to conduct its meetings under the open meetings law so as to encourage public participation whenever time permits and as part of agenda items discussions. Okay, let's first establish a quorum, and when I call your name, please say present. Carol Boyce.
Here.
Ron Broman.
Here.
And myself, Noble Hanson, here. Okay, so today we have something a little different. We're having a public forum on community services, and we have 4 people speaking. Eliza Morrison, Director of Harm Reduction Services, AIDS Support Group Cape Cod. We'll talk about the Community Narcan Training Program. Morgan Eldridge from the Fishing Partnership Support Services will talk on services for the fishing community. Leah Lacrosse, Director of Chatham Community Services, will talk on the Town of Chatham services. And Pat Burke, Shine Program Coordinator, will talk to us about that program concerning Medicare beneficiaries. So we'll get started first with Eliza Morrison, Director of Harm Reduction Services, AIDS Support Group Cape Cod, Community Narcan Training.
Hi everyone, thank you so much for having us back today. I will just provide a little brief overview of our services, followed by a Narcan training. Some of you in this room have already experienced one of our trainings. I'm going to try to keep it brief because I know we're going to try and do this in a timely manner, but just a little bit about the AIDS Support Group of Cape Cod. Our mission statement, as stated here, is the AIDS Support Group of Cape Cod, or referred to sometimes as ASGCC, saves lives through prevention, education, and life-sustaining services that address public health crises to build healthy communities across the Cape and Islands. And here we are doing a Narcan training tonight, so one of the initiatives of our agency is to reduce the impact of overdose on the Cape and Islands through public Narcan trainings, Narcan distribution to the public. Some other services that we provide are medical case management, food and nutrition programming, short-term health navigation, behavioral health services, housing services, and a prevention and screening program which provides cost-free screenings for folks to test for things like HIV, hepatitis C, and other STIs. All of our services are no cost to clients. Some of our services that we provide, like I said, overdose prevention, education, and free Narcan trainings and distribution. Linkage to care for STI treatment and also other supportive services in the community. We partner very closely with lots of supportive services in the community to link people to housing services, food stability services, medical services, and engagement for treatment for substance use services. We provide access to PrEP and to PEP. PrEP is a daily pill taken to prevent HIV, and PEP is a pill that can be taken within 72 hours of potential exposure to HIV to reduce the risk of contraction by about 95%. We are also syringe services program. We provide access to sterile syringes, syringe disposal, and syringe retrieval services. So we are out in the community frequently doing sweeps, looking for areas that we know might have syringes being disposed of improperly. We also go out and we pick up syringes from participants' homes. We make those deliveries, and we also do pickups and deliveries of syringes and other sterile or safer injection supplies to people who do not use illicit substances, so people who are perhaps injecting hormone replacement therapies, steroid therapy, or our diabetic medication. We also provide linkage to care for addiction treatment. We have same-day referrals and handoffs to medications for opiate use disorder and also to detox and treatment facilities. We also provide post-overdose services to people who have either experienced an overdose or at risk for overdose, and also their support networks following a overdose. So our organization operates using the harm reduction principle. Harm reduction, I'm sure you're probably familiar with this term, but if you're not, just briefly, meets people exactly where they're at. We don't require that anyone be abstinent to access any of our services. We know that there is a lot of gray area in between total abstinence from substance use and active substance use, and that if we can help to provide people supports exactly where they are, we can help them to navigate to better outcomes. So the way we do this is educating people on how to reduce harms that are associated with specifically opiate use and other substance use. We don't attempt to minimize the fact that we know that there are very real harms that are associated with substance use, but we do attempt to minimize those risks. So one of the primary things that our programming focuses on is distributing Narcan and getting Narcan into the community. So who should carry Narcan? People who use drugs, not just opiates. We know through our drug checking process that we can provide on site to our participants that not just opiates put people at risk for overdose. We have a very contaminated substance supply here on Cape Cod, so really anybody who uses substances is now at risk for experiencing an opiate overdose. Anyone who lives with or spends time with somebody who's potentially at risk for overdose should carry Narcan, and also community members. We know the data shows us that when a community is saturated with people carrying Narcan and who know how to recognize and respond to an overdose, instances of overdose are lower in those communities. Is it legal and is it safe to carry Narcan? Absolutely yes. Narcan does one thing and one thing only, and that is it acts as the antidote to an opiate overdose. If you use Narcan and an individual does not have opiates in their system, it will do absolutely nothing. It's safe to have around children, it's safe to have around pets, it's safe to have around public spaces. It is perfectly legal to carry in your car and on your person. Everybody in Massachusetts has a standing prescription for Narcan. You can obtain it at a pharmacy, you can obtain it from an organization that distributes Narcan, and you can feel confident carrying it safely and legally on your person. There is a law in Massachusetts called the Good Samaritan Law that aims to protect the victims of overdose and those who seek to help during an overdose. So this law is really designed to make bystanders feel more confident and comfortable responding to the best of their ability and comfortability should they recognize what they think is an overdose. So what does Narcan work on? It works on opioids and only opioids. So when we're talking about opioids, we have two different classes that we're talking about. Number one would be prescription opioids. So things like oxycodone, Percocet, Vicodin. We know now that on Cape Cod, we don't see a lot of these actual prescription pills on the market. What we're seeing are pills that are pressed to look like their prescription counterparts. So people will come to us and maybe they bring us an oxycodone that they've purchased from somebody. When we test the pill using our technology, most often it will come back as as positive for fentanyl with other different fillers pressed to look like its prescription counterpart. So unfortunately, we're not seeing a lot of these prescription medications. But if you do have somebody at home who does have a prescription for opioid medication, then that person might be at risk for overdose. And then we have things like our illicit substances. So we have heroin, fentanyl, and other opioid analogs. We don't see much heroin here on Cape Cod anymore. What we do see is fentanyl and fentanyl analogs. There are over 80 here that we've tested in Massachusetts. And an analog is really anything that's manufactured to mimic the effects of an opiate, specifically fentanyl. They vary from potency about 50 times to 100 times stronger than heroin. So things that might put somebody at higher risk for overdose. Anyone who has experienced a period of abstinence, and this includes people who have never used an opiate before. So if maybe somebody is purchasing a prescription medication that they think is an Oxycontin, and they take it and it's actually fentanyl, that person is much more likely than somebody who has an opiate tolerance to experience an overdose. This also includes people who have been through maybe a treatment program or a period of abstinence because of incarceration. They will have a opiate naivety, we call it. So anyone who has a lowered tolerance because of a period of abstinence is at higher risk for overdose. Changes in the drug supply, we see this a lot here on Cape Cod because it kind of acts as a funnel here. We see different substances kind of come through in waves because they come from off Cape, places like Boston, Fall River, Brockton, etc. So when we see something that's more potent than what people are accustomed to, we'll see kind of a rising rate of overdose for a period of time. Polysubstance use. Opiates are a depressant. So what happens when people experience an overdose is that their breathing is depressed. When the breathing is depressed and they are also using another substance simultaneously, maybe a benzo or alcohol, which are already depressants as well, they have a higher risk for overdose. Also, if people are using something that is a stimulant with something that is a depressant, then we have something that's working on cardiac function as well as something that's working to depress respirations. People who have chronic health conditions such as HIV, hepatitis C, lung disease, heart disease, etc., anything that would compromise their ability to process a substance effectively in the body. Anyone with a history of past overdose is at higher risk for overdose. People with mental health issues like anxiety or depression are at higher risk for overdose. And the number one risk factor for overdose is people who use substances alone. So what is Narcan? Narcan, or naloxone, is a medication that rapidly reverses an opioid overdose. So it is a complete opioid antagonist. So that means that it attaches to the opioid receptors and reverses and blocks the effects of other opioids. Our main concern when we're using Narcan is we want to get people breathing again. So that's what we're trying to do when we administer Narcan, is to get people back breathing. So what happens during an opiate overdose? So an overdose is the body's response to too much substance in the system. Basically what happens is we all have kind of these receptors that just hang out in our brain. They're opiate receptors. We all have them. So perhaps we experience a medical issue where the doctor prescribes us pain medication. So perhaps we have a tooth extraction and the doctor prescribes some Percocet or some Vicodin. So you go to the pharmacy, you pick up this prescription, you take your first pill, and what's supposed to happen is exactly what happens. So that medication comes in, that prescription opiate sits lightly on top of those receptors, tell those receptors, hey, we're not going to feel pain for X amount of time. And then within about 4 to 6 hours, that opiate is flushed from the system. It's done exactly what it's supposed to do. With fentanyl, what happens, because it is such a strong opiate, is that it comes in and it seeks out those receptors, and it binds so firmly and so quickly to those receptors that it almost instantly stops people from breathing. What happens when we administer Narcan is Narcan comes in and it breaks that bond between the opiate and the opiate receptor, and it creates a temporary block on those receptors so that for about 60 to 90 minutes, that opiate in the system cannot return to those receptors and continue to depress that breathing. So respiration is returned. Before we respond to an overdose, it's important to learn how to recognize one. So some things that you'll see maybe when you come across somebody who is potentially experiencing an opiate overdose, and acknowledging that there are other medical issues or medical conditions that can present, like an opiate overdose. So just knowing that we're always calling 911, and even if you do misdiagnose that this person is experiencing an overdose and you administer Narcan, there will be absolutely zero adverse effects. So better safe than sorry, and we always tell people when in doubt, go ahead and give that Narcan. But we're looking for things like respiratory depression. Breathing might be slow, shallow, sporadic. The person may not be breathing at all. If they are breathing, you may hear a very kind of constricted, guttural, shallow breathing that kind of comes from the back of the throat. That will cause those snoring or gurgling sounds. You may see bluish or grayish skin tone from lack of oxygen. Lips, fingernails may change color. They might not be able to answer you when you're prompting them. They might be disoriented or not able to speak with you at all. If you can see their pupils, you'll see that they have very small or pinpoint pupils. That's a hallmark of opiate use. So if you can see their eyes and see that they have tiny pupils, chances are you are witnessing an overdose. They might not respond at all to stimulus. I also tell people, since these overdoses happen generally so quickly with fentanyl, you want to look for the clues. Have you walked into a bathroom and there's an individual where you can see that they've used a substance? Is there a syringe present? Is there powder somewhere? So just be looking and use your context clues. So when we come upon our victim, we're going to assess the level of consciousness. We're going to call out to them, and if there's no response, we're going to call a little louder and give them a little shake. If there's still no response, what we're going to do is we're going to check for their response to pain or agitation by doing something that we call a sternal rub, which is where we take the fist just like this. We're going to use our knuckles to kind of graze the chest plate here. You can also do it under the nose. If there's still no response, we're going to go ahead and we're going to respond using Narcan. So always we're calling 911 first. If you have access to a cell phone, great, you be the one to call 911. If there's a bystander and you can call out to someone to call 911, go ahead and do that. Ideally, we're kind of working with other bystanders to respond. So call 911 is the first thing to do. And then second, we're gonna give our first dose of Narcan. So Narcan comes in a box just like this. There are 2 4 milligram single-step doses in each of these boxes. So giving Narcan is really, really simple. If you've ever used Flonase nasal spray, you can administer Narcan. So what we're gonna do is we're gonna peel the back off. We're gonna place it into our hand just like this. We wanna be mindful that this is a single step administration. So if you accidentally depress this toggle here, then you've discharged your dose and you won't be able to use this Narcan. So be careful when you're taking it out of the package. We're then going to place the Narcan. We're going to take the tip, put it into the nostril, whichever nostril is more accessible. It doesn't matter. We're going to go ahead and place it into the nostril until the nostril touches the fingertips here. And then we're going to go ahead and we're going to press and discharge our first dose of Narcan. And it's as simple as that. And then what I always like to tell people is that if you're waiting for the EMTs to arrive, go ahead and put that discharged dose of Narcan down next to the individual, just so that when the EMTs get there, you can kind of just step away and they know how many doses that you've given. So peel, place, press, and then we're going to begin our rescue breathing if the individual is not breathing. Are you raising your hand? I'm sorry.
Yeah.
Yeah.
So did you say that there's just one dose in that vial?
There is just one dose. So there are 2 single step 4 milligram doses in each of these kits. So this kit contains 2 doses.
Right, and then,
That's-
so it's just one nostril, one dose.
It's 1 nostril, 1 dose. Yep.
And
So
then, yeah, so always call 911.
always call 911.
Now, what about the consent thing? Can a person refuse 911? Can a bystander refuse 911? Can a friend say, I don't want them called? How does that work?
So you always call 911, and then when they arrive, they'll make that determination. Lots of people will opt out of medical care, especially after they've come back around using the Narcan. They actually feel pretty okay, aside from what can be some pretty intense withdrawal symptoms. They can refuse medical attention, but lots of times the EMTs who are really like seasoned at dealing with this at this point can usually convince them to go along and get checked out. Yeah, but they can refuse, yes.
Okay, thanks.
Sure. So if the individual is not breathing, we're gonna go ahead and begin rescue breathing. So like I said, responding to an overdose is based on your ability and your comfortability. If you are not comfortable providing rescue breathing, then we're just going to skip this step and we're gonna monitor the individual for about 2 to 3 minutes. If you are comfortable doing rescue breathing, it's going to be 1 breath every 5 seconds for about 2 minutes. So rescue breathing, we want to take a look and we want to make sure that there's nothing in the mouth. We're tilting the head back and lifting the chin and pinching off the nose. So we're opening that airway and we are closing off that nasal passage, trying to make sure that all of the breathing that we're doing is reaching the individual's lungs. So we're breathing for them. We're going to give 1 breath every 5 seconds, and we're going to continue doing that for about 2 minutes. And then we're going to kind of back off and we're going to assess the situation. Are we starting to see any changes? So is the individual starting to open their eyes? Are they attempting to breathe on their own? Are they wiggling fingers? Are they wiggling toes? Are they trying to talk? So we're monitoring for any positive change. If you do not see a positive change, the end of that 2 minutes, you're going to go ahead and you are going to administer a second dose of Narcan and then start that rescue breathing again if they're still not breathing. If the person is breathing or starting to try to breathe on their own, or they look like they're starting to come around, what we're going to do is we're going to get them onto their side into the recovery position. It's important to put people onto their side because Narcan does put people into what we call precipitated withdrawal. So what can happen is people can vomit. We don't want anyone to aspirate. Narcan can cause a little bit of drainage in the back of the throat. Again, we don't want folks to aspirate. It's also a more comfortable way for people to wake up. It can be extremely kind of jarring and upsetting and anxiety provoking to wake up and see a whole bunch of bystanders kind of looking down on you. And those are the times when you'll kind of see people maybe get up and run as opposed to staying and waiting for medical attention. Yeah, go ahead.
Yeah, so if you come across someone that you presume has an overdose, they're not breathing,
Yep.
Do you recommend that people check for a pulse? Is their heart?
You can check for a pulse.
I mean, are you
So
just-
these Narcan trainings are really designed to make everybody feel as comfortable as possible. Like, you don't have to have any sort of medical experience or basic life support training in order to administer Narcan. If you are someone who's comfortable feeling for a pulse, that's fine. It is more important that we're checking for respirations. So, are we seeing the chest rise and fall? Are we feeling breath maybe? Are we hearing breath maybe?
But I imagine you can get confused with an arrest, a cardiac arrest.
You can. Things like somebody who's just had a seizure, maybe somebody who's had a stroke or a diabetic episode. So all of those things can also present like an overdose. But like I said, no matter what, we're calling 911. And administering Narcan is not going to have an adverse effect. So if you administer Narcan and somebody is maybe post-seizure or has had some sort of a cardiac issue, then we're still getting 911 there and we're checking the box with Narcan. So yeah.
Okay, and then I imagine that some people don't want to do the rescue breathing. Is
Yep.
there a risk to rescue breathing if somebody's taken fentanyl? Can you actually get fentanyl by rescue breathing someone?
So what I recommend is that people use some sort of a barrier or a shield when they do rescue breathing if you have one available to you. If you don't, Sometimes people can pull a shirt over. I have before used my hand like this over somebody's mouth in order to provide a little bit of lift. Generally, people are not inhaling fentanyl, and generally they wouldn't have it on their mouth or their nose area. Touching fentanyl, it cannot be absorbed through the skin unless it's specially formulated on a transdermal patch. So if you were to come across somebody who maybe had some powder on their clothing or whatever and you accidentally touched it, there would be no risk to you for overdose. If you do suspect that the person may have inhaled the substance, could have it on their face, you don't want to put your mucous membrane or any membrane close to that because you could be affected. So if you're uncomfortable or if you're questioning maybe what their mode of kind of like administration of the substance was, you can hold off from doing that rescue breathing. So in lieu of the rescue breathing, we would rescue breathe for 2 minutes. So instead of rescue breathing for the 2 minutes, we would administer the Narcan, monitor the individual for 2 minutes. If there was no change, then we would go ahead and we would administer a second dose of Narcan.
And did you say there's a barrier in the Narcan?
There's not a barrier in the Narcan. Lots of people will carry one like on their keychain. In some of the nalox boxes that we've installed, there are some mouth shields, but obviously those would just be for use on site, and we don't anticipate that there would be an elevated risk of overdose on site because you have a nalox box. So if people carry a mouth shield independently, that's great. I would love if they started putting face shields in here. I think that would be a great idea, but they don't. I have one that I carry on my keychain. So yeah, if you've got a little basic first aid kit in your car, sometimes they have them there too.
Thanks.
Sure. So if the victim doesn't respond to the first dose of Narcan, we're going to go ahead and we're going to administer a second dose. And you can go ahead and you can continue administering doses of Narcan until help arrives. So you can give more than 2 doses if necessary. We do recognize that people do report that they oftentimes have to give more than 2 doses. So this is the recovery position, getting people on their sides. Again, it's a more comfortable and safer way for folks to wake up. I always like to remind people that Narcan is just providing that kind of temporary block on those opioid receptors. So that lasts for about 30 to 90 minutes, depending on when the person has used the substance and how strong the substance is. So we want to make sure that we're being mindful that that opioid may still be in their system. So even after they have, we've helped them to return to breathing and it looks like they've started to come around, they may still have substance present in their system and they can return to overdose. Usually people respond in about 3 to 5 minutes. Some will require more doses, especially with fentanyl. People will be generally pretty confused when they come back around. We want to make sure that we're being reassuring. We have them in that recovery position. We let them know that they're safe. They're probably not feeling good. So where can any community member get Narcan? So we can now, everybody can get it at the pharmacy. Like I said, we all have a standing prescription for Narcan here in Massachusetts. So your local pharmacy, if you just go in and ask, they will be able to provide it to you. You may have a small copay depending on what your insurance is. Pretty soon we will be able to get it over the counter. I do know that you can actually purchase it on Amazon, which is great. This is great for like reducing stigma that's associated with overdose and substance use, but maybe cost prohibitive for some people. It's going to probably be around $75 per kit at the store. Over the counter. You can get it from any of our locations. You can either come and grab it or we're happy to go out in the community and drop it off. It is also available in nalox boxes. You may have seen these. There are 3 in Chatham. So there's one in this building here. There's one at the community center, and then there's one at the Fish Pier as well. So each of these kits, this is to encourage more widespread community distribution of Narcan. This is a great anonymous way to get people who may not have access readily to Narcan in the community. So there's a face shield in here. There are about 3 to 4 kits usually that sit in these boxes. Like I said, there are 3 of these in Chatham. Yeah, so this is just a map of some of the other naloxone boxes that we've installed on Cape Cod. We have about 40 approximately now. And we just got some really great data out of Falmouth, which we know has always been a really high risk community for overdose. We've installed 13 naloxone boxes in Falmouth over the past year, and for the first time in 10 years, the Department of Public Health recognized that the town of Chatham had a marked decrease in overdose, which is really great. So that shows us that it's doing exactly what it's supposed to do. Taking care of your Narcan. We want to protect it from direct sunlight and exposure to temperatures that are extreme on either end of the spectrum. It's important to keep your Narcan where you'll use it. So if having it in your glove box makes it more accessible to you, but it gets hot or it gets cold, you just want to replace it more frequently. Also, when in doubt, use your Narcan, even if it's expired, even if it's been exposed to somewhat extreme temperatures, it will still retain most of its potency. So when in doubt, go ahead and use that Narcan. And if you keep it in a place where it's exposed to extreme temps, replace it more frequently. You don't have to dispose of it any special way when you get rid of your Narcan. I like to keep my expired doses so that I can demonstrate to people how to use it. You might like to do that too, or you might just want to throw it in the trash. That's okay. If you ever use your Narcan in the community, the report backs that we get from folks are really, really valuable to us. They let us know where we need to do a little more distribution in the community, where maybe we should do a little more training. It also helps us familiarize with some trends that might be happening. So if somebody is reporting to us in Brewster that suddenly they're having to use 4 doses of Narcan on someone who's using this substance and that's never happened before, and then maybe we'll hear another person in Brewster also report that to us, then we know that maybe we need to be working a little bit more with Brewster, or that there's something in Brewster, a substance that we should be aware of. And this also helps us when we work with local police and fire departments. So if you, okay, we just talked about that, if you respond or witness an overdose. Also, we have, again, we have the POST program. So our POST program works with people who have experienced an overdose, or family members, etc. We know it's a really traumatic event to witness and also to respond to. So if anybody needs support after that, we have lots of folks in our organization who are trained to do that as well. And that wraps that up. Does anybody have any questions?
Board members, other questions? Ron?
Did you say that anyone can walk?
Ooh.
We get that all the time. Can anyone just go into a drugstore and get one themselves? They don't have to have a prescription or
Nope.
anything?
Everybody in Massachusetts, so there's a doctor named Dr. Alex Wally who works a lot in substance use medicine, addiction behaviors, etc. And he really pushed for this bill in Massachusetts that would enable everybody to have what they call a standing prescription. So it is legal to carry, it's legal to purchase, and anyone can walk into a pharmacy and get it, yes.
How expensive is it to buy?
So if you buy it over the counter, and it's not yet available in stores here on Cape that I know of, people might have like a $5 copay in their insurance. There are some insurances that have a $0 copay. It also depends on how many you get per month. Now doctors, when they're prescribing pain medication, will automatically advise that you also get Narcan at the pharmacy. So it's readily available, and people will not be flagged if they use their insurance to get Narcan at the pharmacy. That's always a concern for people. Am I going to be flagged as, an opiate user? No, you will not. So, yeah.
And then, where do you get your funding from again?
Sure. So we have a bunch of different funding sources, but our overdose education and Narcan distribution, this particular funding is provided by the Department of Public Health.
From the state?
Yes, correct.
Okay. And then, how do you sort of navigate the situation where you're treating the overdose, but then there's concern about getting the patient into treatment?
Yep.
Rehab? I mean, how do you try to have some of that occur? So how do you navigate that?
Yeah, so after someone responds to an overdose, generally, like if We get lots of referrals through our post program, and that can come to us through police departments. It can come to us through individuals who are self-referred. Folks kind of sometimes are referred from their doctor or their practitioner who are saying, you know, this person could use some extra support. A lot of people, after they experience an overdose, are not ready to go to treatment. So harm reduction after an overdose especially is really, really important, making sure that people have Narcan, they have access to supportive services. Perhaps they're not ready to go to treatment, but they would try something like Suboxone or methadone or maybe some outpatient services. So if they do end up going to the hospital will, contact their primary care provider, provide, the reasoning why they were, brought to the emergency department, and then usually we'll get referrals from there.
Right, so you get referrals from somebody that hasn't had an overdose, they just want your services
Sometimes,
from,
yeah.
sometimes.
Yep.
Okay, great. Questions from the people in the room or online? We just, no, okay. All right, well, thank you very much, that's great.
You're welcome.
Oh, Ron, go ahead.
Can someone just buy it and have it?
Oh, yeah.
In other words, if a parent or grandparent knows one of their children are on that, they could have it?
Yeah, absolutely. We work a lot with grandparents who are raising children of parents who experience substance use issues. Sometimes those parents have supervised visitation in their homes, and they want to make sure that, everybody is safe, so they'll access Narcan. Yeah, the aim of putting Narcan in the nalox boxes and doing these community trainings, etc., is to make them available to anybody who wants to know how to use it and is interested in carrying it. Yeah.
It's funny, I'd never heard of that until
Yeah.
we started. But I questioned a couple of kids that I know in the neighborhood there, and they all know what it is, what it's
Yeah.
used for. It's amazing.
Yeah. I mean, we're seeing here in Massachusetts one of the highest rising rates of accidental overdose is in the 15 to 25-year-old age demographic. So that really tells us that these kids are buying pills that are laced with fentanyl, and that they're trying substances maybe for the first time and are opiate naive and experiencing overdose. So it's scary. It's important for parents to know. It's important for grandparents to know. And it's important for, I guess, young people to know as well. Yeah.
So you interact with the schools as well, directly?
We do.
or-
Yep. All of the school nurses on Cape Cod have Narcan that we have provided them. Actively distributing Narcan in school is a much bigger, higher level issue. The school resource officers, most schools also carry Narcan. You can't really have a nalox box in schools at this time, but like a private entity like Falmouth Academy has a nalox box because they are a private entity. It's different working with the public schools, but yeah, all the nurses have it. Yep, we get referrals from them as well. So
All right.
yeah.
Well, great, that's terrific information.
Yeah.
This will all be archived, so actually people can access this talk later on through the town website. So
Wonderful.
we
Thank you
But
so
we'll
much
move
for
on 'cause
having us.
we've got a big schedule.
Yeah. Thank you so much for having us.
Thank you,
Thank you.
Liza.
Okay, next we have Morgan Eldridge from the Fishing Partnership Support Services.
Good, right?
Okay. Thank you all for letting me present to you about our organization. We are Fishing Partnership, and our mission is to improve the health, safety, and economic security of commercial fishermen, their families, and their communities. We have 3 program areas: community health, safety at sea, and economic security. All of these program areas aim to improve the overall health of fishing families. So we have 4 port offices in Massachusetts, all in the major fishing ports: New Bedford, Gloucester, Plymouth and in Chatham. This is our Chatham office. We have 4 navigators, or community health workers in this office here in Chatham, 3 full-time and 1 part-time, which we just hired this year. The need for our services has increased significantly over the last 5 years. And in case you were wondering, community health workers they're public health workers that are embedded in the community, sometimes in community health centers, sometimes hospitals, and they're using their experiences and their cultural competencies to help people connect to services and referrals within their community when they need them. One of our major programs is health insurance navigation. We are navigators with the Health Connector and Mass Health, which means that we're trained at the highest level to be in the community to help people navigate enrollment, apply for coverage, troubleshoot their enrollments or applications, access primary care, behavioral health services, and specialists. We are the only navigator organization from Yarmouth to Provincetown. And although we work with fishing families, this specific grant requires us to work with the entire community. So we help anyone under the age of 65 access health insurance. And just to show you what some of those numbers look like, in the last year, our fiscal year, we assisted 261 consumers with accessing assistance with their health insurance. 200 of those, or 204 of those, were Health Connector enrollments, which means that they were not, they had either no subsidies or they had some subsidies. I'm not sure if you're aware of the programming and how that works, but I can explain it to you. And of those 204 Health Connector assisted is Connector Care, which means that this is a population of people that have a income under 500% of the federal poverty level. They're receiving subsidies in 2 ways: federal tax credits and a state subsidy, which means they have a $0 deductible. We also assisted 57 Mass Health consumers and did over 200 enrollments. 120 of those were Connector Care plans. That's a big population to have on Cape Cod, to have received that much of help. We also provide, yes,
Do you know what the federal poverty level is now?
for a family, for a single person?
Yeah,
Yes, it's $75,590.
so half of that, yeah.
So
Okay.
that's up to the 500%, yeah,
Yeah, thanks.
maximum amount. So that's for 2025. So we also offer mental health and trauma support. So our fishing communities and in Chatham recently have experienced a couple of losses that can tend to be extremely difficult to navigate, especially a population that is challenging to admit when they need some help. We offer counseling for fishermen and their families. And in response to any tragedy, we can mobilize to be in that area to help the community or the family with services. We partner with Riverside Trauma Center out of Dedham. We've educated their providers on the fishing industry, what it's like to live in a fishing family, be a fisherman, being independent, resilient, hard-headed. We've been able to offer 64 people with direct support to that counseling. Our organization has also been able to secure 3 free counseling sessions for anyone in the fishing industry, and that's a 24-hour response. We also offer opioid education and Narcan distribution. In years past, we have partnered with AIDS Support Group. They offered trainings at our trainings. Since 2023, we have received funding to train all of our navigators or all of our community health workers to administer that training. We have adopted a way of doing this by training fishermen as first responders, non-traditional first responders. So as fishermen are, they're out on the water, they're working, and if there is a overdose or they know there's a vessel that is nearby that has had an overdose, they are typically the first to respond. The Coast Guard can take a couple of hours to get to that vessel, so they're there and able to help and save a life. Here we offered this training inside of our CPR and first aid training. So we bring the OEND training to all of our safety and survival trainings as well as our CPR and first aid. So we've always incorporated it into something else to normalize it. There is a stigma around fishermen and as being substance users, and we have worked very hard to break that stigma. We have made them understand that they are actually able to save a life, or why they are at a higher risk of developing a substance use disorder, which is the work that they do is not something that is a typical 9 to 5. It's not something that you can leave and go to the doctor if you're in pain. And fishermen are more likely to be prescribed opioids because of the work that they do, and they're 11 times more likely to die of an opioid overdose. So we also worked with we worked with the United States Coast Guard in Southeast Sector, New England, and they developed a marine safety information bulletin and encouraged all mariners to carry Narcan so that fishermen felt more comfortable carrying Narcan on their vessel. They didn't feel like they would be boarded and scrutinized and possibly charged with something that could get them into trouble. So here's some of the numbers that we have for our training events, and these were all Cape and Islands focused trainings. Yes.
Do most of the fishing boats out of Chatham carry Narcan if they're on overnight
If they have
trips?
come to our training, they have most likely received Narcan.
So you think how many? You think half of them carry it, or a few, or?
These are let's see, through our trainings, if you add these up, this is all of the Cape. I mean, that's a range of people from all over the Cape. So people from Chatham may be going to a training in Falmouth, and people from, like Wellfleet are coming here to a training. So it's hard to determine exactly what the number is for Chatham fishermen that are carrying. But it is likely that most of them are carrying the Narcan on their vessel. In our first aid and CPR class, we give all vessels a first aid kit with $250 or $300 worth of supplies, and in that is 4 doses of Narcan. So if they've gotten that kit, then they've gotten the Narcan. And whether they're carrying it on their vessel or if they're leaving it in their truck, either way, they have it.
Thanks.
I think that's it. I was keeping it brief because I know there was 4 of us that were here. So I'm happy to answer any questions if you have any.
Questions from other board members? No. Your community health workers, you said you had 4. Are they employed by the Alliance, or are these people that volunteer their time and have other jobs?
So we are Fishing Partnership. We're not the Alliance.
Okay.
Fishing
I meant
Partnership
partnership.
Support Services. Yes, all of our navigators are employed by Fishing Partnership.
And it's a full-time job for them?
Full-time. We only have 1 part-time navigator who will hopefully be full-time after the budget is completed. But in the state, we have 9 community health workers, so 9 navigators.
Wow. And then where does your funding come from?
So we have funding from multiple sources. We are lucky enough to have funding through the EOHHS money in the state. Our other funding is through CDC and NIOSH. for the safety trainings. So some of that money comes from Homeland Security money in the NIOSH. And we also have smaller grants. We recently got a Blue Cross Blue Shield grant for developing some mental health curriculum and work there. And then I'm trying to think, I think we have, there's funding
Yeah.
sources from all over, but those are our two biggest ones.
Great,
Yeah.
thanks. Any questions from in the room or online? Okay, yes.
Can you go up to the mic, please?
Right up at the table here, the mic.
Can you go over to the mic? Otherwise. That's okay.
Okay.
Everything's- Is the green light on?
You said.
Push the button.
Press the green light, press the
Green
button
light.
on there. You said that you supply first aid and Narcan to when they take the course. Are they responsible for replacing that? You give them a list when the items expire?
So yes, they get so the first aid kits are very well organized. They have inside the big kit, they have individual bags based on the type of response. There's consumables, there's splints, there's and there is a list, a laminated list of everything that is in there. So once they do use it, they do have to replace it on their own right now. We are hopefully, as we saturate the industry with these first aid kits, hopefully we'll be able to use some of that funding to refill the kits. But right now, we're just focused on getting those out there and encouraging them to refill them when they need to.
Thank you.
You're welcome.
And there are other sources, like the AIDS support group, that could help resupply them.
Yes, with the NARC. So in addition to the trainings, anyone can come into our office and get a Narcan kit if they need to. All of our navigators are trained to do one-on-one trainings or one-on-one handoffs, like a warm handoff. So we can do that in the office as well, in all of
great.
them. Yeah.
That's great.
Okay, great information. And like I said, this will all be archived and available through the website, so people can hopefully look at it later on as well.
Absolutely.
Thank you.
Thank you, Morgan.
Thank you.
And our next speaker is Leah Lacrosse, Director of Chatham Community Services. We'll talk about services from the town of Chatham.
Okay. Good evening, everybody. My presentation is a little bit smaller than the rest, so I figured that I would just first I thought it was important to give an overview of the Community Services Department because it is a new department in the town of Chatham. So the department came about, it was founded in 2022. First director hired in July of 2022. Sorry. What am I doing?
They're just trying to make it so that
Oh, thank you. I'll wait till, oh, it says it is.
He's doing it for you.
There we go. Thank you, Mark. So we were founded in 2022. The first director was hired in July of 2022. That's me. And then in January of 23, we hired our Deputy Director of Community Services and for the Recreation and Beaches Division, Amy Howell. So the way it's structured is Amy oversees the Recreation and Beaches Division. While I oversee all of it, I also serve as the director of the Council on Aging, or as it's known now, the Center for Active Living. And also recently added in May was our adult social worker, Diane Nash. If you haven't met her, I encourage you to. She's fantastic. We're still in search of a youth social worker right now. But Amy oversees all the recreation and beaches staff, including all of the staff that comes about in the summertime, the lifeguards, the seasonal staff. And I oversee directly the CFL staff as well as the social workers. worker right now. We have a lot of services that are offered at the CFAL, and we're adding more every day. We have a very dedicated team of staff that we try to brainstorm new services that were needed and new services as we see the changing needs of the people who come to get services at the CFAL. Right now, pretty soon you're gonna hear about Shine. I don't know where Pat, oh, there's Pat. You'll hear about Shine, which is serving the health insurance needs of everyone. You'll hear about that next. But we have a rather large durable equipment, durable medical equipment lending library. So if you're having surgery, if you're having a knee replacement, or you're in need of a wheelchair or a walker, something's happened, you've taken a fall, we have a lot of that equipment right on site, and you can sign it out. There's no due date. You bring it back whenever you're done with it. Now we are so proud to offer clinical services. As I said, our clinical department right now is a department of one. She's very, very busy, but she has, she works very closely with the police department as well. Even though she's part of the community services department, her office is located at the police department. We did that, we kind of planned that strategically, because most of the time we're alerted to a behavioral health crisis through the police department. And so this way, she's in the office, she can go right to that call and be there right at the time that she's needed most. So she will see people wherever they are. She makes home visits. She sees people at the Council on Aging. We have a lot of older adults that are in need of her services. She makes a lot of referrals out. She does not do counseling, like individual counseling. She will not be somebody's direct therapist, long-term therapist, but she'll make sure you get the resources you need. Our outreach services are extensive. I just put in fuel assistant applications. That's one of the things we do this type of year. Right now we have one full-time outreach coordinator, but she will help with fuel assistance applications. If somebody is experiencing financial difficulties and needs help with rent, she will refer them to the correct services, make those phone calls. She'll help with any, really to provide any resources that are needed, especially we're seeing a lot of food insecurity right now, as you can imagine, with grocery prices and rent prices. So we have one of our bigger programs is Healthy Meals in Motion, and that's run in conjunction with the Family Pantry of Cape Cod. Basically, even though it's run out of the CFAL, anybody, you don't have to be an older adult to qualify. You just come in and see our outreach specialist. You fill out an application, which is basically just your name, address, and phone number, no income requirements. And then you're given it looks almost like a grocery list order form, and you check off what you want. Once a month, I send those into the family pantry, and then on the third Wednesday of the month, a great big giant 18-wheeler appears with all the groceries in the back. And the people who are part of the program line up at the CFAL in front, and we load the groceries in your car and you go. It's a very popular program. When I started, I think we only had 14 people enrolled, and now we have 42. So, and actually we're filling out more and more enrollment forms every day. Again, as you can imagine, food insecurity is huge right now. Also, once they're signed up for Healthy Meals in Motion, they can also visit the food pantry every 10 days if they don't have to wait just once a month for that. Our newest program this past year they're now serving 42 families, should have been on the Healthy Meals in Motion, so I apologize. Yes, question?
Just to back up, so do you deliver meals to homes of people?
So we are, the answer to that is yes. We are the only COA on the Cape that actually most every COA on the Cape participates in Healthy Meals in Motion, but we're the only COA on the Cape that will, if somebody is unable to pick up their groceries, we will deliver them to their homes. We have several that we deliver to.
Is that done by volunteers to the COA?
It's done by our drivers. We have 4 paid drivers that work intermittent hours.
And Leah, you also have Meals on Wheels, which runs out of, that's Elder Services, correct?
Yes, so that's a great point, Judy, thank you. Meals on Wheels is actually a program, even though we have the staff person located in the Center for Active Living, it's a program run and managed by Elder Services of Cape Cod. We just lend them their space. And then they do deliveries to people at home every day.
So you have 4 full-time paid drivers.
Not full-time.
Full-time.
They're more when needed, as needed, per diem.
And then they will drive where else? Will they take people to doctor's appointments and to therapy and to Boston for an appointment, or how does it work?
Great question. So we have drivers. We're doing right now an average about, the answer to that, with the exception of Boston, is yes. We do transportation rides Monday through Friday. Right now, we're averaging between 22 and 32 rides per day, believe it or not. And they are to and from medical appointments. We do only, because we don't charge for these services, we only go as far as Hyannis. But where we leave off, the CCRTA picks up. They do have a bus that goes to Boston for medical appointments several days a week. So we do that. We have, some people will call in orders to the grocery store and charge them, and we'll go pick them up and bring them. We do prescription deliveries to people at home. If there's availability, we will bring them to hair appointments or to the bank, but we prioritize medical appointments first and foremost, so.
Thank you. Yeah.
Yep, one other thing, we also bring them to the Orleans Day Program back and forth because we haven't had an adult supportive day program here in our town. Orleans does, so we have been bringing residents to that program a few times a week.
Is the Orleans program full, or?
I don't know if they're full right now, but we're gonna be, that's actually on the next slide.
Oh.
So I'll tell you more about that. Chatham Better Together is one of our newest, it's on the next slide, sorry. Chatham Better Together is one of our newest programs. And as I said, we try to build programming when we see the different needs. We were seeing a lot of individuals coming into the CFAL and saying that they were really kind of feeling this desperation, this loneliness that was bordering on a desperation. They were isolated, alone. Their kids lived in different states, and their grandchildren, they didn't have anybody. So we applied for a grant, and through the Massachusetts Council on Aging, we got a grant to start a pilot program, Chatham Better Together, and what it does every month, it brings together, right now there's about 35 individuals that come together, and we do field trips. We do things like, I think in the past 2 months, we've gone to, done a Chatham Seal Tour. They're going to the Glass Museum this week. And then they have a lunch. They've also done tours of the police department and the DPW and the fish pier, all sorts of things. This group has bonded tremendously, and we were fortunate to have some anonymous donations and a donation from Bill Bogdanovich and Broadreach Healthcare to continue the program this year. So that's been wonderful. We do blood pressure, free blood pressure clinics through the VNA, foot care clinics, and thanks to the great staff here, we do Flash TV, which it started out as our program person reading our newsletter on the air for Chatham TV for those who had difficulty reading, and now it's expanded to all of our community services. And we offer classes on proper exercise and nutrition. Coming up in January, we're very excited to report that we're starting our own adult supportive day program, the Riders Cove Respite Program. We received a $274,000 grant to start it up and fund the first year. It'll take place on Tuesdays and Thursdays at the CFAL. It'll offer respite care, respite services to caregivers who have been caring for their loved one with cognitive, with dementia-related illnesses. It's going to be a very offer person-centered programs. What that means is we're going to meet with you as a caregiver and say what's most important to you and the person that we're caring for. What are the goals? And we're going to build that programming around that. They'll have a healthy lunch and a daily snack. They'll go on field trips. There's going to be a lot of art and music because that we've learned through research contributes to a healthy mind. So we're very excited about that. We've hired a director and we're putting things together and hoping to open that in January. And other than that, I know there are more services we have, but if anyone has any more questions.
Questions from the board? Okay, I think I asked them as you went along.
Yes.
But, that's great. So this, like I said, this will be archived so people can refer back to it. And
Great.
any questions from the public or online?
I don't see any.
All right, great. Thank you very much.
Thank you.
And then we have Pat Burke, for the Shine Program Coordinator, which is also a Council of Aging service.
Leah and I work closely together.
Yeah.
She's got my slides right up there. Thank you very much. I've been here a few times, as you all know. My name is Pat Burke. I'm a Shine counselor in Chatham. I'm also working with Leah on the COA Board of Directors. And I would like to say one thing before I start. I think the information that people learn from your meetings is invaluable. And I talk you up all the time. And I can't understand why more people aren't here.
Well, you can go to the website and you can get into this meeting, the actual meeting itself,
Yeah.
video. And I think hopefully a lot of people look at it later in the evening or whatever. But
I was
we
talking
appreciate
up to
that.
the finance director today. I sent him the community needs assessment.
Thank you.
So, Medicare, open enrollment. That's really what we're going to talk about. Happens every year. Let's see. Let's talk about Shine. Serving the health insurance needs of everyone on Medicare, except we also help anyone who comes in. We have worked with Morgan on people who need mass health applications, and she's been a lifesaver to us. Our program is federally funded through the Administration of Community Living, which is a part of the Department of HHS. We provide free unbiased health insurance information, counseling, assistance to Massachusetts Medicare beneficiaries of all ages and their caregivers. We also do screening for public benefit programs. There are 13 regional offices covering the state and the Greater Boston Chinese Golden Age Center. There you go. 600 plus Shine counselors. 60% of the Shine counselors are volunteers. Always a question I get when I'm doing my Shine counseling. How can we help you? What we do is help Medicare beneficiaries understand Medicare and mass health rights and benefits. We educate people about all of their health insurance options. What happens most of the time, not in open enrollment, but during the rest of the year, people come in and say, I'm going to be 65 and I have no idea what to do. And unfortunately, the system is rather complex. And when people are trying to decide, oh my God, what am I going to do? I thought this was free. All of us are always able to give them and try to alleviate some of the fears that they have and say, you're going to be all right. We're going to get you signed up and you'll be all set. We try to educate consumers with limited resources on the programs. I know about Morgan's program and other low-income programs that are available. There are big new Medicare savings programs that have come into effect over the last year, I think, And for those programs, there's no asset test. So they're just looking at monthly income, and those programs are valuable in helping people pay if they have high-cost drugs, if they're on inhalers or Eliquis or Xarelto or any of those drugs that cost a gazillion dollars. And they might pay their Part B premium. They sometimes can get SNAP benefits. So it's a program that they're really trying to push because they've taken away the asset test. So you can they don't ask about your house or your 401k or anything. They ask how much money do you get a month. So I think that we've seen a relatively large increase in people being able to utilize these programs. Let's see what else. So 101. Everyone knows what Medicare, I think everyone here knows what Medicare is. Yes, Nolan?
So if someone comes in for an appointment with you, you can actually sign them up for their Medicare benefits right at that time. Go on the website and do the whole
Yes.
thing.
Yes, I
Right.
can. I have great power.
With permission.
Medicare is, as everyone knows, the federal health insurance program that helps with the cost of health care. It's not comprehensive. It does not cover all medical expenses or the cost of long-term care. There are 3 different parts. Part A, which is hospital insurance, that is free. 80%, covers 80%. Part B is medical insurance, covers 80%, but you have to pay for that. Part D is prescription drug coverage, and Part C is what is now called Medicare Advantage programs, which include A, B, and usually Part D. And I will talk about those later because there's some big changes with those. Who's eligible? If you're 65 or older, if you have 40 work credits through payroll tax, you're entitled to premium-free Part A. If you're under 65 and you receive 24 months of Social Security disability payments, you're eligible. You automatically get signed up. You enroll and find out if you're eligible through the Social Security Administration, www.ssa.gov, and it's really important to have a My Social Security account because that's the only way you can enroll. What did I do here? Okay. So, quickly, there are many enrollment periods. There are 7 months around your 65th birthday, which is called your initial enrollment period. Anytime during that time, excuse me, you can enroll in Medicare A and B, or just Medicare A if you're still working and have insurance. January 1st to March 31st is Part B. If you miss your Part B enrollment, that's when you can enroll in general enrollment. Massachusetts has, the Medicare Advantage has an open enrollment plan January 1st to March 31st, only if you are already enrolled in a Medicare Advantage plan. Anytime between then, you can change to another Medicare Advantage plan or opt out back to traditional Medicare. October 15th through December 7th is open enrollment. Happens every year. The dates are exactly the same. We are very fortunate here in Chatham that we're able to serve people 5 days a week, all day, right? And we do have a couple left. I got a couple of people from Howard coming tomorrow because they're mostly booked. You also can get a qualifying event if you move or retire, or if you're incarcerated, anything like that. You have what's called the special enrollment period. So Medicare is not going to tell you to enroll when you're 65 unless you already get the Social Security. So you must call Social Security or go online and enroll. Medicare and Social Security are 2 entirely separate programs, but to get Medicare, you have to go on to Social Security. Now, it's very easy to enroll online. If you have a My Social Security account, you click Medicare, and it walks you right through it. It's not a difficult thing to do, but we are able to help people with that. I've set people up with my social security account so they can get through the programs. Delaying Medicare Parts B and D. So this is interesting. You need to decide if you want to take Medicare Part A. If you delay Medicare Part A, there's no penalty. If you are still working, you're still getting health insurance through your spouse, you don't have to sign up. You can sign up when you're 65, it's free. But if you're contributing to a health savings account, you have to delay your Medicare Part A because you need to have about 6 months not contributing to that account before you can sign up. If you do not sign up for Part B when you are initially eligible and you do not have credible health insurance, there is a lifetime penalty for not signing up for Medicare Part B. And that is 10% for every 12 months that you haven't had Medicare Part B. I can tell you that I had someone come in to see me recently, and their penalty was 100% because they had not signed up for 10 years. So it was a bit shocking, and I hate to give people such bad news. If you enroll late in a Part D, which is a drug plan, you have 2 months after you sign up for Medicare to enroll in a Part D plan. There is also a lifetime penalty for that. And that is, they figure that out. They gather the aggregate of what the Medicare drug plans were and what they were paid, and then they tell you what the penalty is. It depends on how long it hasn't been. I've had people that have come in that had a $40 a month penalty, and people that have come in that have had a $4 a month penalty. But that penalty is lifetime as well. And it's unfortunate, yes.
So if you're signing up and say you're not on any drugs, any medications, the numbers work out so that you should still sign up for Part D and pay for it?
It doesn't matter whether you're taking drugs. If you don't sign up for it.
Right, but they may feel they don't need it.
They don't ask, they
but they
just
do.
say, do you have a plan?
They should still sign up anyway.
So you would sign up for the most inexpensive one.
All right.
As I said, there are two choices. Original Medicare, Part A and B. Well, with Original Medicare, you add a Part D, which is a prescription drug coverage, and you can also add what's called a Medigap. They're a Medicare supplement insurance. We are fortunate here in the state of Massachusetts. We have 7 providers that offer Medigap insurance. There are 2 types of Medigap insurance you can get. Regardless, they are regulated through the Massachusetts insurance industry, and regardless of what the provider charges you, they are all required to give you exactly the same thing. So people that are paying more money aren't getting better benefits. There are 2 types of those plans, and they do tend to be, they're a bit more pricey. They can go anywhere from $115 up a month for the lower plans up to $285 a month, which, it can be quite costly. You have to have some funds to be able to do that. The Medicare Advantage plans, Medicare Part C, I'm sure you've all seen those ads on TV. Put your zip code in and we'll give you a free ride to somewhere. I don't know where. My husband keeps wanting to put that zip code in, and I told him he's going nowhere. Medicare Advantage plans include everything. They include Part A, Part B, and drug coverage. Almost all of them have drug coverage. There are a few that don't, but they usually include all 3. So your Part B payment goes right to whoever your Medicare Advantage provider is, and it's one bulk payment. These plans have a multitude of types of costs. They can cost anywhere from $0 a month to $240 a month. They are because we live in Massachusetts, they are very good plans. The plans that we have here are very good plans. The challenges we have here is we live on Cape Cod. There are only 3 providers that provide Medicare Advantage plans on Cape Cod. They are Blue Cross Blue Shield, Tufts, and Fallon. And those are the only ones. And I'm going to get more to that. So we talked a little bit about your Medigap. There are 2 types, Supplement 1A, available to all who are eligible. It covers pretty much everything. The only thing it doesn't cover is once a year, $240 Part B payment. These can be costly, though. You know, a Supplement 1A plan is at least $230 a month. Supplement 1 is what people often refer to as MedX Bronze, and those plans are available to people, as you can see, who turned 65 before January 1st, 2020. And those are the most expensive plans, and they cover everything. The positive with these plans are you can go anywhere. You don't need a primary care doctor. You don't need a referral. You can go any place within the contiguous United States, Hawaii and Alaska, and parts of Canada, and you will be covered. You will not get a bill. Everything will be covered, and that's why people choose these plans. They have discounts, you know, if you enroll early, if you don't get everybody the paperless billing. They've added a few pluses. Some of them have some dental coverage. Some of them have, for a couple of bucks, you can get eye and ear coverage, which is helpful. Now we're back to this. Well, okay, Medicare open enrollment once a year, October 15th through December 7th. January 1st is when, if you change your plan, when your new plan will take place. The only reason it's important is, well, the one reason is because there are changes every year, every single year. This year we saw dramatic changes with the Inflation Reduction Act. We saw changes in the number of providers for Part D plans. We saw prices go up significantly in many of those plans, and we also saw some changes that were positive for people on expensive medications, because they can only charge you $2,000 in a year. There's no more donut hole like gap coverage. They can charge you $2,000 within a 12-month period for drugs. If you go over that, you don't get charged for that. But we look at those every single year, and it's a good idea to come back in and just, you know, get a look at them, make sure you have the best coverage for whatever you have. I can't tell you the number of people that have said, oh, I haven't been in, I never came in. And then you say to them, well, you're taking 2 things, you could be paying $35 or $40 less a month. So it is important. Is that the, wait a minute. No, oh, you can do it yourself. You can go on Medicare.gov and log in and create an account, and it will get you to find your own health and drug plans. If your medications are bought through a drug plan, they'll all be on there. You won't even have to add them. And you can look at the drug plan and see what's available, what plan you have, what's a better plan. See how much money you're going to save. It's not easy to navigate this website. I will tell you that it's pretty busy right now. But if you are going to go in, you need to sign up for a Medicare.gov account. It's very easy. All you need is your Medicare card, your last name, your date of birth, and your current address with zip code or city. And when your Part A or Part B coverage starts, they ask you to pick a username, pick a password, and pick a secret question. And once you get that information, you can get in and see everything. You can see all explanation of benefits, any procedure you've ever had done that through Medicare will be on this website. So it is helpful. Medicare Advantage. As I said, those plans are January 1st, you can change those plans. If the example here is a bit apropos, because I did send to Judy something that had come out about the Medicare Advantage plans, and I didn't have a slide for it, and it was a little wordy. But what I would like to tell you is this. We have 3 providers, as I've said. Blue Cross Blue Shield has 7 Medicare Advantage plans available to Barnstable County. 3 of them are HMOs, 4 of them are PPOs. Fallon Health Plan has 4, and Tufts has 8, and all of Tufts are HMOs. The issue this year is Blue Cross Blue Shield, when they were doing their contracts, decided they were no longer going to contract with community care centers. The community care centers on Cape Cod that are utilized for many of the people who have these plans are Out of Cape Health Services and 2 places in Mashpee and Falmouth. So it's been a huge deal. Blue Cross has not notified their clients yet. They plan to do that on November 15th. But Out of Cape Health Services has sent a letter to their clients letting them know that if their primary care provider is an Out of Cape Health provider, they will no longer be covered by the Advantage plan that they're on, that Blue Cross plan that they're on. And they will either have to pick a different Medicare Advantage plan or go somewhere else to get their care. So this has been, we brought this to, ran it up the flagpole to everybody, and Julian Sear got involved. And I was on a call with him, and he's, trying to do what he can do. The problem is you're notifying people November 15th. Open enrollment ends December 7th. Nobody has any openings, and what people are having to do is call 1-800-MEDICARE. And it's really challenging. I dealt with this myself last week with a client who had this, and we were able to change her primary care physician to someone at Fontaine, but she was going to get a visit sometime in July of '25, and we don't even know if that will happen, but we hopefully got her a primary care provider. It is a very big issue here because a lot of people have these Blue Cross MA plans, and it was very concerning when we heard about it and listened on the call and listened to Out of Cape Health talk. The CEO of Out of Cape Health was there, the people from Blue Cross, and it seemed like it boiled down to what where Out of Cape Health and the other 2, Mashpee and Falmouth, fell in the HEDIS, what's the word I'm looking for? The quality metrics. And that they didn't say what quality metric wasn't what they wanted to be. But when I was doing a little more research on this today, I saw that almost all of their plans almost all of their metrics are 5 stars, but a few of them are like 4 stars. So Blue Cross would like to be a 5-star plan because that's a huge plus to be a 5-star plan. We have not had a 5-star plan in Massachusetts in a long time, so I'm sure they are looking to do that. Yes, no?
So if you sign up for a Medicare Advantage plan,
Yes,
is the company obligated to find you a PCP locally?
no,
You have to search for it yourself?
Yes.
Call offices and find out if they accept it
yeah.
or not?
I mean, what
Get a
we
list, I
did
guess, somewhere.
was we went on the Blue Cross website and looked for PCPs in 02633. And they pulled up one fellow at Fontaine and other people at Outer Cape, but we couldn't use them. So we were able to sign up for that person, but you have to do it yourself.
Right, so the big problem, on the Cape is getting a PCP. So signing up for Medicare Advantage doesn't necessarily help you there over
Right. You have to have
traditional.
if you sign up for a Medicare Advantage plan, you have to have a primary care provider. You can't, it's not like a Medigap plan. You
But
have to,
does the company make sure they provide you with one, or is it up to you to find one?
it's up to you to find one.
So if you are on Blue Cross Blue Shield Medicare Advantage,
Yes.
and you are a member of a community, if your primary care is either at Outer Cape Health or one of the other two community health centers in Falmouth, then you're being dropped, is basically what you're saying, by Blue Cross Blue Shield Medicare Advantage. So the choices then are to find another provider, which we've just said is very difficult. Could they switch to a different Medicare Advantage plan?
The challenge is this, the other two, Fallon Health Fallon's a Central Mass provider. They're picking up more contracts on Cape Cod. I am not could not say with 100% that they have a contract with Outer Cape Health yet. They were working on the contract with Fallon Health so that they would have a contract with Outer Cape Health.
Okay, so that's,
And the difference is, of the Blue Cross plans, 3 of them are HMOs, and the other 4 are PPOs. So the network is broader, and oftentimes people who are looking for somebody that may be outside of the Cape Cod healthcare system will look at one of these PPOs because it'll give them a little larger provider group. All of the Tufts plans are all HMOs. So when you sign up for a Tufts plan, you're signing up for all of your providers are here on Cape Cod. So it's a big change. It really is a big change for people. And I would say more to come, but there's not that much time left before people. I did suggest that maybe they extend their final day to the end of January to give people more time to make the change, but they've changed who's on the call, so I don't know the answer to that question.
is there, contact your state rep? I mean, I know
We
Julian
did.
already knows.
Yeah, he knows. I mean, he was very, he was upset about it. It affects a lot of people. If we read the community-based assessment you did, Chatham is the second oldest population in the state, and Orleans is second. And these are his constituents, so he's trying to do the best he can. The challenge becomes trying to understand what the process is. And because it's Medicare and because the process is so complex, it's difficult, when you just come in at all of a sudden and say, oh my God, this is a nightmare, but what can we do about it? There were many ideas that were floated, but unfortunately, I do not think there is any Council on Aging or the county office that has any open appointments for open enrollment for people. I mean, we try to squeeze them in. We work hard in Chatham to make sure we can squeeze in as many people as we can in a day.
You mean shine appointments?
Yeah, so
Yeah.
we can help them, but,
Leah, can you go up to the mic?
I can't do any more.
No, I just wanted to add to it that now they are, to confirm with you, because you may not know, they are all full now, including the county.
So everybody's full. So I don't know the answer to that problem, but I think it's important information to have. I think it's important that you know, in case anyone ever asks a question, and you can always refer them down to Alexis at the CFAL, and she'll reach out to who's ever there that day or send an email to one of us, and we do the best we can to help people, to call them back and see what we can do.
Yeah, so if you, early in the enrollment period, if you went in and signed up for a plan, and then you get more information, and you want to change the plan before the enrollment period ends, can you go back in and
Yes.
change what you?
Yes.
Yeah.
So you can. It's, I mean, I've been here more than once when we've had the primary care physician talk, and that's the challenge. I mean, the woman who came in wanted to choose a physician who's listed on the Blue Cross website as taking patients, and when you call, she is not.
Yeah.
So, you know, and we've let them know that, so that maybe they can update their website, but, you know, it is what it is, but I think it's important information for everyone to know, just in case they're in this dilemma. The Inflation Reduction Act, this is the impact. 35 maximum monthly copays for diabetes medications. 5% coinsurance for Part D catastrophic phase coverage. Yeah, that's all last year, so that's done. What happened in '25 was they eliminated the coverage gap. They put out-of-pocket spending, as I said, at 2000s. And now what they've done is they've developed what's called the Medicare Prescription Payment Plan. So let's say you sign up for a plan, the deductibles, the new deductibles are $590 on most drug plans, and you are taking a lot of drugs and some expensive ones. Your costs in January could be $1,100. You can call the drug plan, and you can say, I'd like to sign up for this Medicare prescription payment plan. And what they will do is divide the money over the 12 months. So you will pay your premium, and then you will pay for the drugs through the drug plan. And then, oh, a little close to the mic there. And then you will not have to pay CVS or Stop and Shop wherever you get the drugs. It's a little, it's new. This is the first year. So I haven't noticed anyone signing up for it yet, but we can't sign you up for it. You have to call the drug plan to sign up for that. But it's a good step. There are drugs coming up in, this is what I just said, you know. So, Mass Health can help with drug costs. The Medicare Savings Program, as I said, is extremely helpful to people who have high-cost drugs, high-cost inhalers, high-cost Xarelto, Eliquis, all of these drugs that right through the roof. Ozempic, people who are taking it for, type 2 diabetes. Prescription Advantage used to be bigger than it was. It's a little less now with the Medicare savings programs. And there are manufacturers' plans. There is a place called needymeds.org, so if you really can't afford it and you go on that website, you can oftentimes get some help from people. Morgan talked about the Health Connector. We don't do too much of this. We can, for people, that are going to lose their Health Connector coverage, we can help them with it. We can sign them up for Medicare if they're eligible, but it's not really a big part of our jobs. Just some, there are strict guidelines. This is good information for people who, you know, start watching TV after tomorrow. And then once there'll be, you know, Joe Namath will be back and, you know, whoever else telling you that you can have all of these things. And what happened was, a few years ago, Medicare received 161,000 complaints regarding those advertisements. And so they've put some very strict guidelines into place that if you call one of those people, they have to identify themselves as a broker or an agent for the insurance plan, so that people are not misled and don't get offered things that, quite frankly, they're probably not eligible for and won't get in this state. So those are the things you can, that are a positive that have come out of that, because many of those advertisements were, you know, people would come in to me, a 95-year-old guy came in and said, "What do you think? Should I switch to what Joe Namath has?" And I said, "No, you're good. Stay where you are." So don't miss your deadlines. Disenroll from the Health Connector if you're on it. Be sure your doctors are in the network of the Medicare health plan you're choosing, kind of a key point today. Make sure your meds are all on the plan's formulary, because sometimes they're not. Consider setting up your own Medicare.gov account. And remember, review your plans every year between 10/15 and 12/7. There's a couple of little Social Security, Medicare, the Mass College of Pharmacy, they do some good outreach, Prescription Advantage, Shine. Unfortunately, everybody's kind of booked up. So there we go. Thank you very much.
Great, that's good information.
I didn't know I would be lost.
No, that was great.
Questions from the board for Pat? Or any from online or in the room?
No, you guys,
And
but I'm
then-
going to keep talking you up.
You are,
because
excuse me?
I think you need, people really need to know what you're doing. I think you're doing important work here, and I don't think enough people know it. So,
Let me ask one other
you, Pat.
question. One of the big things you hear is like chemotherapy drugs, experimental drugs, very expensive, they're not in your drug plan.
chemotherapy drugs, most chemotherapy is Part B, because they're infusions administered in a hospital. The newer drugs, like Ozempic I utilized, that's so new. You know, they don't divide out who's taking it for weight loss versus who's taking it for type 2 diabetes. You know, it's very effective on type 2 diabetes. I can tell you my husband's hemoglobin A1C was 9. He took Ozempic. It's 5.9. I mean, so it's a very valuable drug. You know, he did lose a few pounds, but, you know, it's good.
Okay, great. Well, thank you very much. It's good
Thank you.
information. I agree. And
I'm
it's, like
sorry
I
I
said,
was
it's
last.
archived, so hopefully we can get the word out and
I will.
get more of the knowledge around. But I thank all the speakers. I think it was really helpful and worked out pretty well.
Can I just put one more service that we do have available? And I've mentioned before, we have a recovery coach in town who's here once a week. She is being supported by our opioid settlement funds. We have a 3-year contract. We're about 1 year into it, and she's been very effective and been working great with our team here. So anybody who has any questions or concerns about families or their friends, or has any type of substance use disorder, not just opioids, I urge them to reach out to Kelly at the police department on Wednesdays. Or they can call us and we can help them get in touch as well. So,
Okay, great. Thank you very much.
Thank you.
Any other old business, new business? We have the minutes to approve from October the 21st. Motion?
I'll make a motion to approve the minutes.
And a second?
Second.
All in favor, say aye.
Aye.
Motions are, that the minutes of October 21st are approved. And then I guess I can take a motion to close the meeting.
I'll make that motion to close the meeting.
And all in favor, say aye.
Aye.
Okay, good. We are adjourned. Thank you.